Good evening and welcome to this ESOT webinar titled Living with Chronic Allograft Dysfunction or CLAD, When Life-Saving Treatment Fails. I am Veronika Müller, transplant pulmonologist at the Department of Pulmonology, Semmelweis University in Budapest, Hungary. And with me here to chair this webinar this evening is Professor Are Martin Holm from Oslo in Norway.
Thank you, Veronica. We're going to discuss some very important topics today, starting with a brief outline of the burden of disease for patients with CLAD. And then Stefano Pavanello, who is a patient representative from Padua in Italy, will tell us about the patient perspective for patients who are transplanted. And after that, physiotherapist and Master of Science Veronica Rossi from Milano, Italy, will discuss the benefits and opportunities of respiratory rehabilitation in CLAD. Before you, Veronika Müller, tell us about the development and implementation of palliative care in CLAD. And finally, we will have time for questions. So everybody, please write your questions in the chat.
Before we begin, I would like to thank the organizers at ESOT for putting this together. And I would especially like to thank Sanofi for the generous, unrestricted financial support of this webinar. Now, let us begin. Are, please tell us about the burden of CLAD.
Thank you. So, the topic of this webinar is living with CLAD. And if you look at this slide, this is unpublished data from our center, and it could have been from any center. This is how usually the occurrence of CLAD is presented. So on the left side, you see a typical Kaplan-Meier survival curve. You can see the numbers there are the number of years. And if 100 persons are transplanted, then some die. And you can see how many are still alive. And on the right graph, you can see people who are either dead or have developed CLAD. And you can see here, if you can see my pointer, that it seems to be 10% more after a year who are either dead or have developed CLAD. It's a bit difficult to read slides like that. So to demonstrate to you the burden of CLAD, I have looked at data from our center, and I actually went into all the patient files of a cohort of patients and just counted the reasons for death. And if you look at figure A on this slide, this is the reasons of the reason patients died during a period of time. And if you see the blue sector here, it shows you that about 33% of the patients died from CLAD, actual CLAD. And then about 25 or 26% died from some infection, either with or without CLAD. And then you can see some malignancy and so on. So you can see CLAD is an important cause of death. And if you look at panel B, you can see that this is the dominating cause of death in the first years after transplant. And only after 5 or 6 years do other causes of death come up to the same significance. If you look at people who develop CLAD, and I will say a few more words about how many those were, but if you look at panel C here, these are those who developed CLAD, and among those, 70% actually died from it. The rest of those who died from something else. Which is also important to keep in mind. If you look at this slide, I hope that this shows you a little bit clearer something about the burden of CLAD, the occurrence of CLAD. And in this total material, we found that 33.3% of all the patients developed CLAD within the observation time that we had. In the literature, these figures vary from somewhere around 25% to maybe 50%. I recommend everyone at your center to look at the data that you have, because they may be different than this. So this is just an example. But out of these 33% who developed CLAD, if you now look at the left panel there, you can see that time 0 is when they were transplanted. And you can see that about a third of those who develop CLAD do it within the first year. And within 2 years, about half have developed it. And within 5 years, 80% have developed CLAD. So what you learn from this is that CLAD develops fairly early after transplant. The right-hand slide shows you what happens when people have developed CLAD. This is the time from developing CLAD to death. And you can see that some develop a fairly rapidly progressing disease. So up to 30% of those who develop CLAD actually die within the first year after transplant. And if you remember the blue line on the slide, on the previous slide, this is what that reflected. But you can also see on this slide that about 30% live more than 5 years, and some even longer with CLAD. The title of this webinar is Living with CLAD. So if I just color this area under the curve orange, the orange color represents living with CLAD, and the topic here is how to live with CLAD. What do we know about that? There are a few publications out there. This is just one example I'm showing you from John Singer at the University of California in San Francisco, who has developed a quality of life questionnaire for patients who are lung transplanted. And in one of the tables in this paper, the authors compare those patients who have developed CLAD with those who haven't, actually severe CLAD in this case. And you can see immediately on the top line there that pulmonary symptoms, of course, are more frequent in those who have developed CLAD. That's clear. But what I want you to take home from this picture is that also a lot of other symptoms are very frequent in those who've developed CLAD, like, for instance, gastrointestinal symptoms, worry about future health, obviously cognitive limitations, that's important, sexual problems, that's important, health distress, maybe not that surprising, but pain, maybe a little bit more surprising, social function, energy, and fatigue. All of these things belong to the picture of living with CLAD. Another paper, which is maybe a little bit more complicated, from the Hanover Group in Germany, has calculated the dysfunction-adjusted life years to calculate the burden of living with CLAD. What I'm going to do now is just show you the highlights from this paper as pulled out by the authors themselves. So they found in Hanover that 1 out of 4 lung transplant recipients develop chronic lung allograft dysfunction. So this is 25%. Remember, we found 33. What they also importantly write further down here, as CLAD disability slowly develops within a median of 2 years, just as in our material, there is room for better management of CLAD. And I want to finish with these words, and that's why we have this webinar. We need better management of CLAD. So this webinar is not going to be about novel treatments for CLAD. It's going to be about how we manage CLAD. So maybe we're missing something. We need to ask the patients, and the next talk is going to give us the patient perspective. And then we need to make the most of it once people have developed CLAD. So we're going to hear about rehabilitation and physiotherapy for CLAD. And finally, we need to address how to handle the rest of life. We need to hear about palliative care for CLAD. So this was my introduction to this webinar. And I give the word back to you again, Veronica. Thank you.
Thank you so much. And that is a great pleasure to introduce Stefano Pavanello. He will present us the patient perspective. Thank you so much for being with us, and the stage is yours.
Thank you. Good evening. I'm Stefano Pavanello. I'm a patient transplant recipient and also a patient representative. So what I'm going to tell you comes from my experience as a patient and a patient representative. I apologize in advance to clinicians if some points are not perfectly scientific. I don't have any disclosure, and I also permit that my presentation is shown on social media. Lung transplantation is a very complex journey made up of many steps that often begin even before you are put on the waiting list. In my case, I started thinking about transplantation when it still didn't exist in Italy. I knew I had a progressive, incurable disease. And even though I was very young, I was 7-year-old, I understood that transplantation was probably the only way for me to survive. So I spent most of my time waiting for transplantation to become possible. After several contacts with the transplant center, in 2011, I decided that it was time to take what I felt like a gamble. And in 2012, I underwent a bilateral lung transplant at the University Hospital of Padua. I was informed soon that I might soon face acute rejection, infections, viruses, and even tumors. And then another one, which is CLAD. But CLAD is something that you don't really think about at first. With the passing of years, when I realized that most of these risks that I have listed can be in some way managed or treated, I began to let go my fears and surrender to the new life. But after some years, the one that initially seemed to be less worried starting to bite my mind like a woodworm. Whenever I had a cold or a flu, or when maybe I could feel some difficult to breath, the thought is, and if it is CLAD, I was informed that, in this slide, you see how transplant recipients feel in their moment of reflection, because we really think that we have a date, of duration, or something. Sometimes we can also feel like this when we are really negative about our situation. And then it happened that we get to know more fellows that are facing CLAD, and our future feels uncertain again, because receiving a CLAD diagnosis is like crossing a threshold that wipes away all the new life that we had received with the transplant, and we go back into our old fears. With CLAD, we just don't lose our breath. We lose some of our will to fight. Over time, I have learned to recognize those friends who have been diagnosed with CLAD from the tone of their voice, even over the phone. At first, they try not to worry you, so they remain vague. My spirometry is worst. Maybe I need photopheresis. But I can hear their faint and disillusioned tone, the one of someone who doesn't feel fighting. And why does it happen? Because deep down we feel that what is happening is inevitable. If it happens, you just have to try to face it. Younger patient might have the option of a retransplant, which is extremely challenging even for the strongest, but it's still a real chance. Those who cannot receive a retransplant often rely on photopheresis, a treatment with certain uncertain mechanism and results. Someone it is described with maybe, it seems, or it should help. In my life, I have only heard of one person that say with certainty that photopheresis works. Later, I found out that she worked for the company that makes the device. So I believe in science and research, and I know that many people and doctors, scientists, researchers are working for us. But we patients have many questions, but not so many answers. Questions that are not really for us to solve. For example, could research focus more on preventing bronchiolitis? After all, it seems to me that it's been decades since a new anti-rejection drug has reached the market. In conclusion, transplantation is not just a medical procedure, it's a chain of expertise, dedication, and emotion involving dozens of people. The result is a new life, something that cannot be reduced to survival statistics. Help us not to feel we have an expiry date printed on our foreheads. Thank you.
Thank you so much, Stefano. It was really good to hear the patient voice, and we will go on with some questions to you. First of all, considering all the risks associated with transplantation, what message would you like to convey to all those considering lung transplantation?
Yes, I know it's difficult to decide to put in the list for the transplantation, even if we see statistics or, for example, the one the professor showed us before. But first of all, we have to rely on our doctors, and if they consider the transplantation, it means that we really need the transplantation for having a better life. And what I want to say that it doesn't mind how many years we have, but the quality of life. And I can assure that you can have 3, 4, 5, 10 years of new life and a really good life with transplantation.
Okay, I have to inform the audience that Stefano actually deliberately made his talk a little bit shorter, and he asked us to have this dialogue, and I think that's excellent. I would like to ask you, Stefano, do you think that patients, when they are enrolled on the waiting list before the transplant, do you think patients are sufficiently informed about the risks, not only of the surgery, but also in the entire post-transplant care? Are you sufficiently informed, do you think?
I think that what is important is a tailored information. I mean, sometimes the patient is already very scared, So in this case, I think that too many information maybe are not the best choice. But if patient is enough ready, it's important to explain what could happen during the year of his new life, in order to be prepared, to face all the things I have listed before.
Okay, I actually, Veronica, I would like to ask you one more question, Stefano. Adding to this, do you think that when patients have developed CLAD, right? Do you think that the doctors and the nurses are good enough to ask the patient of what concerns they actually have, apart from having the respiratory CLAD?
I'm sorry, but I have to say no. Sometimes this kind of information are given only by psychologists. Doctors are very limited regarding the mental situation that a patient felt when he's facing CLAD. Because as I tried to explain in my speech before, CLAD is not only a disease, it's something that imply very mental health, because you immediately think of your life before the transplant. You think of using again the oxygen, and is something that is very difficult to live, not only because of the lack of breath, but also for your feelings.
Okay, I think that's. Thank you very much.
Thank you.
Thank you, Stefano. I think this is also an excellent option to work together. You as a patient advocacy person, just that we can manage the expectation of our patients. So I think this is also an excellent possibility, and thank you so much. So we would like to move on. So if CLAD is already there, what can we do? And this is my great pleasure to introduce Veronica Rossi from Milano. She will tell us about the benefits and opportunities of respiratory rehabilitation in CLAD. Please, Veronica.
Thank you, Veronica. Good evening, everyone. It's a pleasure to be here. In the next 30 minutes, I will focus on the potential benefits and emerging opportunity of pulmonary rehab in patients with CLAD. I will briefly frame the functional pattern after lung transplantation, then discuss what happens when CLAD develops and why rehab may represent a key and a therapeutic strategy. So we know that lung function transplantation significantly improves lung function. However, exercise capacity doesn't fully normalize. So even in long-term survival with normal spirometry, peak oxygen uptake typically reach around 75% of predicted values, and exercise capacity is influenced not only by FEV1 but also by age. We know sex and diffusion capacity. So this suggests that exercise limitation is multifactorial and therefore potential modifiable. So when CLAD develops, the clinical profile changes. So progressive airflow limitation leads to dyspnea, reduced exercise capacity, and peripheral muscle dysfunction. So over the time, this results in functional decline, reduced quality of life, and increased healthcare utilization. So importantly, exercise intolerance in CLAD is not explained by lung function alone. So we know multiple mechanisms contribute, including ventilatory limitation, impaired gas exchange, peripheral muscle dysfunction, and treatment-related effects such as steroid myopathy. So this complexity is important because many of reduction in walking distance in patients developing CLAD often predict more evident clinical deterioration. From a physiological point, from a physiological perspective, one of the main drivers of exercise limitation is ventilatory impairments. So we know about the reduction in walking distance in patients developing CLAD, often preceding more evident clinical deterioration. So this means that function decline can be detected early and potential target. So one of the most useful tools to monitor functional status after lung transplantation is the 6-minute walking test. And in this study, we show that 6-minute walking distance is strongly associated with post-transplant survival, making it not only a functional measure, but also a prognostic marker. So in clinical practice, we know that lower distance means worse survival, and higher distance obviously means better survival. So it represents a simple but powerful tool to monitor functional pattern over time. So at our center in Milan, functional monitor is fully integrated into the long-term follow-up of lung transplant receipt, and the 6-minute walking test help us to guide rehab prescription and allows early identification of functional decline. So in our cohort, we observe progressive and reduction in patients with CLAD, often proceeding more evident clinical deterioration. So this means that functional decline can be detected early and potential target. And from a physiological perspective, one of the main drivers of exercise limitation in CLAD is ventilatory impairments. So as the disease progresses, the patient requires stepwise escalation in respiratory support, so from conventional oxygen therapy to high-flow nasal cannula, CPAP, and non-invasive ventilation. So this reflects increasing ventilatory demand and reduced respiratory reserve, which differently limits exercise tolerance. So in this context, even lower intensity activity may become highly demanding. So, however, the limitation is not only pulmonary, so respiratory muscle function also plays a crucial role. So using ultrasound, diaphragm function can be assessed through the thickness fraction as a marker of contractility, and reduced values indicate impaired diaphragm function, so contribute to dyspnea and exercise intolerance. So at the same time, peripheral muscle dysfunction further amplify functional limitation. So quadricep ultrasound, for example, in this case, allow to object assessment of muscle thickness and cross-section area, and loss of muscle mass significantly contribute to reduce exercise capacity independently of lung function. So based on this, rehab in CLAD should not be seen as a generical intervention, but as a target and physiological drive strategy. So aerobic training should be adapted to the presence of ventilatory limitations. So in patients with CLAD often stop exercise because of dyspnea. So during continuous exercise, dyspnea increase quickly and leading to early interruption. So in contrast, interval training introduces short recovery phase that allows partially recovery of ventilation and muscle metabolism. As a result, symptoms increase more gradually, enabling patients to keep going exercise for longer. So in CLAD, symptom tolerance rather than muscle capacity is often the key factor, limiting factor. So another important limitation in CLAD is exercise-induced desaturation. However, peripheral muscle dysfunction is another important contribution to exercise limitation. For this reason, we aim to monitor and to investigate quadriceps function. So in this video, we use one maximal repetition to prescribe the training load for home-based exercise. So even without sophisticated equipment, the intervention can be tailored to the individual. So resistance training should be set by objective assessment rather than prescribe empirically. And in our center, we use we longitudinally monitor muscle structure and function using, for example, ultrasound, dynamometry, and functional tests such as I mentioned, 6-minute walking test or 1-6 repetition. So this assessment allows us to track change over time and adapt rehab program accordingly to patients, obviously, as well. And resistance training is typically prescribed at moderate intensity, around 60% at maximal strength, obviously in accordance with the clinician, with the patient as well, and 2 to 3 times per week with progressive adjustments based on the symptoms. So in selected patients, obviously, we prescribe as well inspiratory muscle training, or we consider it inspiratory muscle training. Airway clearance is often required in our patients, the airway clearance technique. So, and in selected cases, it is delivery with the support of non-invasive ventilation. So we monitor the efficacy of this intervention using, for example, ultrasound. And for the future, what does the rehab intervention in the future? So one major challenge in CLAD is maintaining long-term adherence to exercise training. So patients often experience progressively function decline over many years and may live far from transplant center. So we know that in this context, tele-rehab represents an important opportunity to maintain exercise training and functional monitoring remotely and supporting long-term adherence. So looking ahead, the future of the rehab in CLAD will likely by hybrid formula, combining central-based expertise with home-based, obviously, and digital strategy. So to conclude, what we observe in clinical practice is not only decline of lung function, but progressive loss of functional capacity that directly affect patients independently and in daily life. So in this context, rehab should not be viewed as the optional intervention, but as an integral component of long-term transplant care. So even when we are unable to modify the underlying disease partner, we still have the opportunity to modify the function decline by targeting ventilatory limitation, muscle dysfunction, and symptoms burden. So for the clinician, this means integrating systematical function assessment to routine follow-up and approaching rehab as a dynamic ongoing process than one time and time limitation intervention. So in the end, even when lung function decline, we can still make a meaningful difference in how patients live with their disease. Thank you for your attention.
Thank you very much, Veronica, for that excellent talk. I would like to seize the opportunity to remind everyone that you can put your questions in the chat, and we will answer questions after. I can see there's one question at the time, but please feel free to enter your questions. Now we will now have the final talk, and Veronica Müller from Budapest will tell us about the development and the implementation of palliative care in CLAD. Please, Veronica.
Thank you so much. It is my great honor to be part of this panel, especially as I'm representing a region which is just which was later coming into the transplant field, especially for the lung transplantation. So we had some years that we had to catch up as compared to our colleagues who were having this option formerly. But talking about CLAD and palliative care, I have nothing to declare as regard to this topic. And I want to come quickly to the point that, yes, chronic rejection and the CLAD is a well-known entity since years or maybe since decades. We see that some patients are losing quickly function. Both phenotypes are well-known, the BOS and the RAS. Both are both are diseases where we have functional decline and also histological and radiological changes what we see, and we have to communicate to our patients. I also put this very important research into my talk about the Hanover Big Transplant Center, just to highlight how much DALI, disability-adjusted life years, are lost due to the CLAD. Actually, when you are dividing it into the two parts, nearly 1.3 life years are lost, and an additional 0.8 years are additionally lived with severe disability, and this is the point where I want to put in palliative measures. This altogether adds up nearly to 2 years of DALI, and this is something we really have to address because there is a lot of room for improvement and better management, especially as we heard in the first talk in the early years after transplantation. So what is palliative care? What is the definition? The World Health Organization defines palliative care as an approach that improves the quality of life of patients and their families facing problems associated with life-threatening illness through the prevention and relief of suffering by means of early identification and impeccable assessment and treatment of pain and other problems, physical, psychosocial, and spiritual. So it's really something very complex. However, we see that there is roughly over 56 million people in need of palliative care, but only 14% of people who need palliative care are currently receiving it. So there are big differences according countries and regions. Definitely some national policies and programs are needed just to overcome this burden. The global need for palliative care, however, will definitely continue to grow as a result of the aging of population and the rising of burden of non-communicable diseases and some communicable diseases. Delivery of palliative care will reduce unnecessary hospital admission and the use of health services. And it's very important to emphasize that it involves a big range of services by different professionals that all have equally important roles in the play. So these are physicians, nurses, support workers, paramedics, pharmacists, physiotherapists, and volunteers. They all have to support the patient and the family. So what about organ transplantation? In solid organ transplantation, palliative care is also very interprofessional, consistently associated with improvement in advanced care planning, patient and caregiver satisfaction, quality of life, symptom burden, and lower healthcare utilization. What is the role and what are the benefits of palliative care? Definitely we need physical symptoms caused by CLAD, like dyspnea, insomnia, pain, nausea, fatigue. There are a lot of different problems. This we definitely have to address. There is second big problem is psychosocial distress, which may include management of depression and anxiety, and especially we need to support the families or the caregivers who are also coping with a lot of fear from the illness. So definitely we need to explore also the spiritual beliefs of the patients and the values just to define the goals of care. We definitely need a care plan with the illness understanding and clarification, what does it mean, and advanced care planning, and everything has to be patient-centered. The care coordination, I think this is a very tricky part because we need to coordinate a lot of care providers, like also from health services, but also social support and community services. From my point of view, what I see in our system, we have the biggest problem with care coordination. There are no dedicated people who can really deliver coordinated care. There are some special centers where specialty palliative care can be provided, but not close to the home of the patients. So what is the unmet need? First, there are a lot of studies and articles about what should we call palliative care, or do we need some rebranding or renaming, because there was or still is a strong stigma and association with end-of-life care. So it has been suggested that we have to educate public, families, and patients, healthcare providers, and we should leave palliative care, not rename or rebrand it. When you are looking at the picture, the first panel is showing a classic way of treatment. So we are using life prolongation care as long as we can, and then where all the possibilities are exhausted, then palliative care or end-of-life care can be delivered. However, it is much better to start with palliative care programs early. So when life-prolonging care is limited, then we can come back and make more close contact to our palliative care team, and so we can manage patient needs together. And it's a very important point that you see on the end of this graph is bereavement. We also have to take care of the families who might lose one of their loved ones. When we are looking at the transplant care, a lot of, like also we heard in the talk before, most of our patients, they are facing already a life-threatening disease, and then the transplantation is coming. So when the transplant is failing, they have again a new phase where they have to cope with a lot of stress and a lot of difficulties. So this is the last graph or mark we see. So what does palliative care mean to our lung transplant patients? First of all, I think we have to understand the definition and the complexity of this adjunct therapy. It's a adjunct therapy, and it's not end-of-life care. The complexity should include symptom management and coping strategies, and the most important part that we have to enroll the families, and so they can be in charge when dealing with difficult health problems. The introduction of palliative care team takes time. I remember my first talks about possible lung transplant and how patients are feeling. So when I am talking about palliative care, I am always emphasizing that please remember how you felt when we first touched the issue of lung transplant. So if patients got palliative care before the transplantation, I think they are much more willing to accept it also during the CLAD period. However, we have provider gaps in palliative care, and I do not consider myself a specialist. So what can I provide as a transplant physician? I deliver definitely some routine palliative care. I can manage symptoms and guide treatment decisions. We also give some basic support, psychological support. However, complex and refractory symptom management and coping with spiritual distress or existential matters, grief support, specialist level guided care planning, or psychological support to the caregiver are something that only specialist teams can deliver. Most important is the impact of CLAD on quality of life, as mentioned already before. There is always a general quality of life, which is significantly decremented. Additionally, the physical quality of life is changing as mobility and energy declines and dyspnea worsens. So patients are more closed in, cannot move so much. So it's also a very big distress in their social connections. Mentally, anxiety and depressions increases. They do fewer activities, and not only the recipients but caregivers also perceive CLAD as a returning to a pre-transplant state, and there is a lot of feeling about loss of transplant gains. There was a very nice structured review which was done among 38 transplant pulmonologists from 9 high-volume North American centers who are dealing with lung transplant. And the focus was how pulmonologists viewed specialty palliative care and decided to refer transplant recipients, including those with CLAD or chronic rejection. Most of the physicians distinguished specialty palliative care from hospice. I think this is very, very important. However, there were two opposing transplant philosophies which were driving the referral behavior. The 45% saw it as a very important tool already in the beginning, like in oncology, where we have to face a lot of times quick deterioration of the patients that they introduce quickly alongside with the treatment, the palliative care, while the other one, 55%, saw specialty palliative care only after everything has failed. And it was also something they were finding very challenging when referring patients for the transplant. Two unique barriers were identified. The first one was the 1 year metrics, because in the first year it was much less easy to refer patients for palliative care, even if it was well known that they are deteriorating. And the second one was the opioid fear, especially for addiction or respiratory harm, and maybe the jeopardy of retransplant candidacy when patients were on opioids. And we have to address, and I think this is the most important part, what me also dealing with patients don't have enough time, and I am no qualifications for the caregiver. And I think this is something we definitely have to address. There is a huge unmet need for the caregivers, because a lot of times they feel unprepared for the experience. They have a lot of worries about the health, the finances, and their own well-being. They experience huge decline in quality of life and high caregiving burden a lot of times. They themselves experience fatigues and clinical depression, and we know that caregiver strain is associated with worse post-transplant outcome for our recipients. So we have to deal with our caregivers. So the real gap, what we can see is that there are actually no cross-sectional or longitudinally assessed palliative care studies about the needs of lung transplant candidates or recipients or their caregivers, and we don't have really validated instruments for showing real benefit or how to use it. And I just want to show that the CLAD onset, we really have to re-engage with our specialist team, how we can best support our patients and families who have CLAD, and what is their requirement. I am showing two trials which are maybe the closest what we can expect. There was one randomized control trial of palliative care following bone marrow transplantation. The question was, what is the effect of inpatient palliative care intervention on the quality of life during hospitalization for hematopoietic stem cell transplantation? So it's at the acute phase, and it's a 2-week palliative care. And as you can see in figure A, that during these 2 weeks, yes, there is a huge decline in quality of life in both groups. However, the decline is less pronounced when palliative care was introduced, and the recovery was also much quicker. I think these are very important points, that patients could recover much more quickly. Again, on panel B, you see depression, and on panel C, anxiety. So mostly these two domains were very much lower and less expressed when palliative care was administered. However, on the burden of the symptoms, that was not such a big influence. So this is a severe procedure, but with the intervention, a lot of benefits could be shown. There are also some other trials, where randomized control trials of palliative care delivery in critically ill patients were examined. In this randomized control trial, the question was, do palliative care-led informational and emotional support meetings improve anxiety and depression symptoms for family decision makers of patients with chronic critically ill patients in the ICU. So it's very, very special situation, and mostly focusing on the caregivers. However, the randomized control trial included a lot of families over 250 adults were the patients, and a lot of family members were included. However, the family symptom scores for anxiety and depression were not really different for the intervention and no intervention groups. Also, the hospital length of stay and the 90-day survival from randomization did not differ. So at the end, maybe some conclusions and take-home messages. I think the main take-home message is that there is no published study that has directly compared quality of life outcomes in CLAD patients with or without palliative care using a validated instrument in a controlled design. So I think there is definitely a big need to see what is really helping and how. The post-CLAD palliative care evidence gap is explicitly acknowledged in the most recent literature. I know it also from our center that we had this very nice talk about rehabilitation. For example, rehabilitation wording in my country is something, this is also a little bit strange and a lot of times associated with palliative care. So we introduced this as lung fitness because this is something which patients much better understand and they are much more willing to undergo cardiopulmonary rehabilitation measures, and they really like the wording. So we had trials where another transplant setting randomized control trial, this is one of the closest available, which demonstrated that integrated palliative care measures can improve quality of life in a transplant population. But I think, as already mentioned, we are in urgently need to see how and what kind of measures can explicitly help in CLAD, as we have seen that it's significant, it has a significant outcome on the DALI burden. So identification of patient and caregiver profile, profiting the most from specialty palliative care is also needed, as we have some data that the reaction might be different from family to family. So I think this is also a very important point to consider. With that, I would like to thank for your attention.
Thank you so much, Veronica. This was very interesting. We now have time for questions, and I can see in the chat there that we have a few questions. Do you want to take the first question, Veronica?
Oh, yes, and it's directly to other Veronica. So does your center use 6-minute walk test beyond 24 months, for example, at an annual review?
Thank you for your question. You mentioned a very important point in specific time frame. So following the guidelines, we try to assess the functional status after 1-2 years using obviously 6-minute walking test, and for example, specifically for functional status, we use as well 1 minute sit to stand. So maybe in a tele-rehab way with a stable patient. However, in an unstable patient, obviously we try and we study muscle function and aerobic capacity as well. Thank you.
Yeah, I think I can add that at our center, we have it in our protocol to do a 6-minute walk test every year for the remaining of their life. But I think when there are many years out, many have various reasons for not doing the 6-minute walk test, but at least we try. And I think it's very useful. It's very easy to understand the test, I think.
Yeah.
So
we also do it.
Yeah, sorry, you also do it. Yeah. I think it gives a lot of information, and it's a cheap test, and I think it also reminds patients that physical activity means something. Right. There's another question, maybe Veronica, you could answer. Is there evidence that rehab intervention for CLAD delivers improved survival and improved quality of life? You may have shown some of it, but a short answer.
We try to perform a preliminary study, so we need to publish the data about it. But we are not really randomized control trial, rehab versus non-rehab, for example, usual care in this type of patient. So I think it's very challenging just to found the control group, for example.
Okay. Can I ask you a question that I have? What would you say is the most efficient training or exercise that you would recommend patients who have CLAD? The single most efficient thing that you would recommend?
I think following the guidelines, aerobic training, for example, in which it's cheap exercise, but very useful in terms to improve FIR1 and improve as well to decrease the symptoms, obviously, and it very helpful just to the humor, to the physiological point of view. So it's important just to propose a type of exercise in which patient can include in the community as well, not only in the hospital setting, maybe in like outpatients, something like normal setting as well.
Okay.
May I ask also, maybe Professor Holm, that about the palliative care measures in my country, for example, home palliative care is not something we can deliver. What is your perception in delivering maybe home-based palliative care to transplant patients?
I have to admit that we have no real good system for that, and when the patients are in that situation, they are treated at other hospitals, because we have one transplant hospital and we do the annual follow-ups of each patient. But it has always bugged me a bit that when patients get ill enough and there's nothing more we can offer them at our center, they are decentralized back again to where they came from. And even though we have some contact, we don't have a good enough system for following up the palliation, I have to admit. And I do think that this is the case in many places. So this is definitely an area where I think the professional community could improve. I definitely think so. What do you think? Do you think transplant physicians or surgeons are reluctant to refer patients to palliative care? And if you do, then why?
In Hungary, we have not too much availability for palliative care, and it's mostly reserved for oncology patients. So we are really much trying to incorporate any kind of chronic disease now into the care. It's a very limited possibility, at least in my country. So there is always a big burden, I think, for especially for the families to get help when they have a big need for support. So this is why I am very much in favor somehow to emphasize how much we can also do with the construct and combination of the classic transplant care and the palliative care, especially for the families. I think they are in much need.
For the caregivers. Yeah. I wondered you were, I saw a sentence on one of your slides that transplant centers have a survival focused care.
It was
from the paper of Nolly and co-workers. The survival focused care, the glamorous life-saving business of transplantation. And could it be sort of standing in the way of actually delivering good palliative follow-up?
I'm sure that a lot of centers where the palliative care is very close and they work together, it's very good to use. I think it's always depending on the availability. So I found the reasoning and the attitude very, very challenging, that you have this, it's always these two sides of the same concept. And I think this is what we should maybe a little bit talk more about it, that this is an important aspect it's really patient and family. I would say that this is a little bit bigger scope.
Yeah. I just want to read the final question now. What would you suggest a patient diagnosed with CLAD, concerned about their local provision does not maximize their quality of life? And there clearly is variable provision across Europe. I think that is definitely true. And I think I would say that I don't have a good answer to whoever this, Mr. or Mrs. Peniche. Oh no, that's the person who wrote the question. So I don't know where the question came from, but I don't have a good answer. But I think we have to work on this to improve the rehabilitation and the palliation for CLAD, and not just focus on novel treatments. That's important, but we need to remember that it doesn't always work.
It was a fantastic hour. Thank you so much. And thank you all for your excellent questions. Thank you for logging in and attending the webinar. Thanks also to all the speakers, to ESOT for arranging this, and to Sanofi for the unrestricted grant to making all of this possible.
Thank you all so much, both the presenters and to you in the audience. Thank you all so much, and goodbye.